Hi everyone, Kevin Davies here in Boston with John Halamka, who was the opening keynote at Medical Informatics World, the inaugural conference, the sister conference to the BioIT World Conference that will be running the rest of this week here at the World Trade Center in Boston. John, great to see you again. Thanks for keynoting, the first man in history to keynote both BioIT World Expo and Medical Informatics World.
Well, an honor and happy to be here.
So you gave a fascinating sort of a TED-style talk in 20 minutes touching on all the many challenges and things you have to do in 20 hours a day, 365 days a year as the CIO of Beth Israel Deaconess. Tell us about what are some of the major challenges that you're wrestling with day to day at the moment.
Well, it used to be that a CIO could focus on a hospital or a clinic, but in a world of accountable care, you're focused on the community. And that means 100% adoption of EHRs in every setting of care, but also the business intelligence and analytics behind that for care management. It's not sufficient to say, hey, I'm going to look at your record today and make sure you're getting optimal care. I have to look at the community and in a continuous way, deliver right care, right time, in right setting. Totally different tools to do that.
So you began by talking about ICD-10. Why not briefly tell us what that is, what that stands for in a pretty acronym-rich field, and what are the challenges that poses?
International Classification of Diseases is a wonderful epidemiologic vocabulary. Of course, every country in the world will want to understand how much flu or how many heart attacks or what strokes they have. Challenge, of course, in today's era, we have much more granularity. If, let's imagine I'm rock climbing in New Hampshire and I catch my ring finger in a crack. Well, today, ICD-9, the current vocabulary, literally has a finger problem. That's it. ICD-10, left, ring finger, crush injury, distal, open. It's a vocabulary that requires deep clinical documentation way beyond anything a doctor does today. So I have to build novel tools that tell a doctor, is their documentation sufficient or not, helps them decide what code to use. And then once you have the code, you can use it for quality measures, decision support, etc. But it requires retooling every clinical system we have.
Talk a little bit about patient data security and privacy. You gave one fascinating anecdote about a doctor whose private laptop was stolen and the pain and grief that this has brought you because this was not a John Halamka certified, encrypted, double secret machine.
Well, exactly. So recognize that new HIPAA regulations took effect on March 26th. They're enforced as of September 2013, and they include $1.5 million fines per institution per year for privacy breach. So Office of Civil Rights is really stepping up enforcement. And this isn't just, again, as you say, the traditional inside the four walls. It's, oh, a doctor has chosen to use a device like this one, and there's an email on that that has a patient identifier. Oh, and it's lost or stolen. It now becomes my problem. So we've had to encrypt every one of these devices, not allow network access for the BYOD or devices brought in externally without specific controls. And it requires a cultural change because clinicians, being mobile people, are used to being anywhere in the world. Oh, I'm on a hotel computer in Kyoto today. I'm going to go read my email. What if there's no antivirus, there's malware, and it's taking and screen scraping and keystroke logging everything you've put in? Again, becomes my problem. So a lot of new controls and restrictions have to be put in place.
I think you mentioned you're currently managing about 3 petabytes of data, and your
Correct.
talk was mercifully spared of the big data buzzwords. But A, is that data really going to grow dramatically in the next few years? And B, what approaches are you taking to really mine that data with your colleagues?
So the 3 petabytes grows at 25% per year. Okay. And it's image data as well as structured data as well as unstructured text data. So our tools have to be normalized structured data into business intelligence and analytic repositories across the community. With unstructured data, natural language processing. How do I discern meaning, especially looking at subject, predicate, object relations? Who did what to whom? And how can I use that for quality measures, care management, or even individual patient care coordination? And then image sharing. That's another interesting one because it's not sufficient just to keep static repositories of images. You now have the redundancy and waste of too many radiology tests. How do I share those out in the community? So it's building systems that translate data into knowledge, information, and wisdom and sharing it with the community while keeping it secure.
Right, right. You, of course, as I think most viewers will know, were one of the very first volunteers in the Personal Genome Project, one of the very first people on the planet to have their genome sequenced. Are you seeing any signs that exome or whole genome data is starting to become an integral part of patient management?
We're certainly seeing in oncology the use of genome data and sequencing in tumor markers much more extensively than before. So when my wife was diagnosed with breast cancer last December, immediately she's sequenced. We find out, the nature of her risks. A tumor is sequenced, look at the nature of how to treat it. Her chemotherapeutic regimen, her surgery, radiation was totally targeted based on those sequence elements. Haven't yet quite seen the I, as an individual, as you know from my genomic sequence, have twice the average risk of prostate cancer compared to the average male. My primary care clinician knows that, but there's no place in the EHR to record probabilities of prostate cancer and build alerts, reminders, decision support. So cancer, yes. General care, not quite.
Right. What impact, this is a hopelessly a vague question, but what impact do you think health IT is going to have on medical care? Where do you think information technology advances are really going to impact patient health care in terms of your specific disease areas or other aspects of health care?
So I trained in emergency medicine 20 years ago. Yeah. It was an apprenticeship. It is art. Now, I think we can all agree, there's evidence, there's science. Today's IT systems don't quite yet incorporate all the evidence and the science, but I think in the next few years they will. So when I go to order a treatment, it is not because of my apprenticeship. It is because evidence suggests you should follow this care plan and this guideline. If you should vary from that care plan or guideline, then we pull you back to the care plan and guideline. It's this standardization of care that will improve quality and reduce cost.
And John, you said 4 hours before your keynote this morning, you were there on your farm shoveling manure. This must be a very interesting place to sort of gather your thoughts and ponder the challenges of the days and weeks ahead.
Well, so a year ago, my wife and I bought a farm, and it really is a working farm. And one of the things I stress to all my staff is equanimity, and that is emotional evenness. And it's really actually much easier to deal with compliance and regulatory and IT and technology challenges if you have the humanity of shoveling manure at 4 a.m. It makes you humble, it makes you calm.
Well, you can read about John's adventures on his farm and at in the data centers and labs and wards of Beth, Israel Deaconess on his blog, Geek Doctor. Look it up. And John Halamka, thanks so much for opening Medical Informatics World this morning. Great to have you here.
Great, a pleasure to be here. Thank you.
Thank you.